off with the table over here. You were looking at this issue of detail.
We've got 5 points, and I don't know how well we address the question.
There's always one group that says that.
Well, start off as you mean to continue. There's always talk about, say, the top 10 indicators that people should look at, but these can't be the same or prescribed, and because they're going to be different for every organisation. So that's the first point of call. Variation is the key to this. It's going to be different in every board. Too much is as bad as too little in terms of what's reported through. Confusing, you can confuse as much as anything else, and too little, well, that's obviously the case. But whatever goes to board, the board needs to be able to, it needs to be structured around the actions to be taken, because these are complex organisations, and therefore it's very clear that you can't just swamp them with loads of stuff. It's got to be structured around actions, and there was something about a very good governance structure underpinning the information that goes to the board. And in sort of UHB's example, they only take exceptions to the board. It's not everything, it's only the exception reporting. The data has to be timely, so it has to be the last month. It can't be you lose the ability to act. But underpinning it all was really having a board with the skills to set the agenda around what they want to see, but also the ability to challenge and understand the data they receive. Because it's complex data, and therefore they've got to be able to ask the relevant questions about what they're seeing.
Sure, and I guess is that the data comes with some explanation of actions. That's the bit that the board can scrutinise, as well as how did we get in this situation in the first instance.
Yes, yeah, that's what we mean by actions. It is actually, well, we need an action around this. It's not just notify and ratify the paper. This is actually do something about it.
Okay. Any others have got coming on this point? But this is about boards that are they either underwhelmed or overwhelmed with detail. Any comments on what you've heard? Okay. Robert, I know you had a question that was slightly around this. Is that
yeah.
time to put that one in?
What struck me slightly with some of the presentations was the question I've asked in other contexts, which is what people think about the relative importance of information analysis, whatever, reports on what I'll call basic standards, which can be either the minimum required standard in any field, but also the more basic standards in relation to nursing care, for instance, difficult to measure and so on, but that sort of level of information. And a lot of what I think Martin was talking about, which is a drive to improvement. An unkind comment might be made about Martin's presentation is that in itself, and I appreciate he'll have other information, but in itself, I had no idea whether the baseline from which the improvement was happening was fantastically good or absolutely awful. And as a member of the public, the first thing I would likely to want to know is this a safe place? Not is it fast improving from being highly dangerous to just a little bit dangerous? I appreciate your comments on that.
Any comments on that? We better give Martin the opportunity to respond.
Well, actually, I agree with you, of course, and I think it is absolutely right that we are able to benchmark performance across the piece on those levels, and that's why I mentioned benchmarking. But many people have asked, where is the bar, and can a hospital at a low bar position improve? And I don't think it's necessarily always possible to go to the high level bar from the low level bar without allowing some time to elapse and for the culture to change. And so I don't think, unless it's so bad that you want to close it down, or that there's some big turnaround action that you can take. But if you can't, if it's somewhere in between those two things, then I think you have to allow this concept of continuous improvement. And I personally would expect to go both to a place which was at least good and committed to improvement, because that, I think, is something of expressing the underlying core culture of the institution.
Now, I wouldn't suggest you don't have information about improvement, but I was just asking where in the panoply of everything we've talked about there is the information about the attainment of the basic standard, other than the fact that it's got a CQC license.
Benchmarking is critical.
Can we, Tony, can I put you on the spot? Are you expecting boards to have those absolute and relative information on standards?
Well, I'm certainly expecting them to have relative information on standards. The absolute is extremely difficult, as what is the absolute? So we have the minimum standards of quality and safety from CQC. The reality is that the perception of what the minimum standard of safety is does change over time. So that's never actually going to be an absolute, and we hope it creeps up over time as performance and sort of standard practice improve. But that's never actually going to be an absolute. And then the moment you get into, let's look at sort of individual procedures and different areas of the hospital, we know in some areas from the statistical analysis that there is dramatic sort of improvement in quality at certain inflection points, or the other way, dramatic falls off in quality at certain inflection points. But we only have the data which allows us to do that for quite a small number of procedures. I know NICE is working on doing this for more and more and more, but you can see it in things like sort of cardiac surgery because the data's there. The moment you get into things like sort of geriatric care and so on, the data is so much poorer that, so where is that point? It's just very, very hard to tell.
But just because it's difficult doesn't mean to say
Doesn't
that
mean
the board shouldn't be looking at it.
It doesn't mean that, but it does mean the board is going to have a very hard job to actually tell it.
Martin, do you want to come back on that one?
Well, I just wanted to make the point as well that a good board should be considering both the quantitative and the qualitative intelligence. And I think the key is about being able to synthesize those correctly, because very often it will be qualitative information that might tell you about certain lapses in standards in certain areas within the organisation. I think the other issue as well is recognising that dialogue. It's not a case of saying we will set 10 key sentinel indicators for all time. It's about a board challenging the executive and challenging the organisation to assure it that it's delivering standard, the right quality care.
I mean, you as a group, you highlighted that you shouldn't have one set of standard indicators for all organisations. I guess when they become standard, they become a target, and organisations will veer over to those and perhaps lose some of the things that they ought to be monitoring as well.
Exactly.